if you've got any, thank you. So if you've got any questions at all, you can just pop them in the chat box. So on your, you can see on your screen there's a Q&A box, so please do. We are hoping for lots of questions as we go along, and there will be a poll at the end just to ask for your feedback straight away, so that'd be really helpful. Okay, so we'll crack on. Okay, so we've got lots of panelists today. We've got Dr. Shruti Narayan, who is our SHOT Medical Director, and she's also a consultant in donor medicine with the NHSBT. We've got Dr. Alison Watt, who is a human factors expert and is also part of the SHOT steering group. And we've got Emma Milzer, who is our SHOT Haemovigilance and PBM specialist. We've got Dr. Jennifer Davies. She is a transfusion lab manager and also part of the UKTLC, and she's also part of the SHOT steering group and WEG group as well. We've got Kerry Dowling. She is the UKTLC chair and also a transfusion lab manager down in Southampton. We've got Karen Hughes, who's our SHOT operations manager, and we've also got Chris Robbie, who I'm sure you know, he's our MHRA haemovigilance specialist. Okay, so the first slide is obviously a thank you for attending, thank you for listening, and thank you for continuing to report to SHOT and to MHRA, because without you we wouldn't have the data to enable us to look for learning, and thank you for wanting to improve transfusion safety in your organisation. We will absolutely do our best to do that over the next 90 minutes. Okay, so the outline of the webinar, we're going to have an overview and background from SHOT. We're going to have some insights as well from Chris from the MHRA perspective. We're going to look at the application of human factor principles. We're also going to specifically look at the human factors investigation tool from SHOT and look at some illustrative cases to really explain that. We're going to have some input from the UKTLC regarding surveys and standards that are all relevant to incident investigation also. And we're also going to look at a holistic approach to safety and have a look what available resources there are and draw some conclusions. And absolutely, we'd really like you to get involved as a Q&A. We've allocated a large section of this presentation to a Q&A because we'd really like to hear from the users out there. Our learning objectives, okay, we'd like to understand the importance of effective investigations following an incident. We're going to identify how we can optimize that learning from the incidents and how that contributes to transfusion safety. And we're going to explore corrective and preventative actions and again how that will influence future incidents. And we're going to look at some case studies, and hopefully we'll be able to look at those case studies and really that will cement the learning throughout the presentation. So I'll pass on to Karen, who's going to follow me. Thank you.
Thank you, Nikki, and hello, everybody. SHOT, as most of you will be aware, it stands for the Serious Hazards of Transfusion. It was established in 1996 and is the UK's professionally mandated haemovigilance scheme. It encompasses all of the following elements that are in the infographic below. It is centralized, it is linked but professionally independent. It collects confidential and anonymized information in a passive format. It is professionally mandated within the UK. It is non-punitive and limited and also collects data on near-miss reporting and learning from excellence. The basic premise of National Haemovigilance System is the development of a coordinated approach, but haemovigilance is not a static system and it is always evolving. Furthermore, it relies on a coordinated approach to the continuous improvement of transfusion safety. The following image is an image of the transfusion blood supply chain and just really signalizes that there is room for learning from incidents across the entire transfusion, from the blood chain to ensure that the reduction of error requires effective and improving safety. This requires communication between all teams, right from the donor teams to the recipient teams at the patient's bedside. This infographic shows that transfusion is a complex multi-step process involving many members of different professional groups. It relies on the collaboration among staff, and that is vital in ensuring that the right component is transfused to the right patient at the right time. There is potential scope for error at any stage along the way. Adding to the complexity in managing patients in general is the shared care and multiple teams, which creates complications along the way. When we talk about transfusion safety, we are inclined to focus on components as such, but it is also about process-based safety. And although transfusion safety remains paramount, it is very vital to consider process safety within the transfusion chain. Often when we're looking at transfusion incidents, we forget that the impact can be variable. It can range from no impact at all to effective resulting in a patient death. What potential impacts do transfusion incidents have? I think we forget sometimes that not only the patient is involved, they have a far-reaching impact. There's the patient, of course, who's and severe distress to the family, emotional and professional impact on the staff involved in the incident, and a cultural impact on the department as a whole. Added to that is the reputational damage to the organization. Where staff are highlighted as the sole cause of error, this is likely to have a negative effect on healthcare organizations with no improvement in patient safety. The following graph shows the cumulative data for shot categories from 1996 to 2021. And as you can see from the graph on the right, this demonstrates that errors continue to be the largest portion of incidents reported. The majority of these are preventable. What is interesting aspects are which have been identified as contributory factors across when we have received reports on errors. These are inadequate resources, poor system design, suboptimal incident investigations, and ineffective preventative actions. The following infographic shows investigating and learning from incidents and the influences that these aspects have on how organizations investigate and learn from their safety incidents. They include local trust and health board, network guidance, NHS England, Northern Ireland, Scotland and Wales, of course, regulatory requirements, SHOT and the UKTLC and other influencing factors. Thank you, and I will now hand over to Chris Robbie from the MHRA perspective.
Thank you, Karen. Thank you for inviting me to speak. If you go to the next slide, please. Blood safety and quality regulations define the terms for serious adverse events and serious adverse reactions. And it's the 2006 amendment which inserts the requirements for reporting serious adverse events and reactions. The key points from MHRA's point of view is that all relevant information should be reported as soon as known. It is a requirement of the blood safety and quality regulations to identify preventable causes. There may be many causes within a single report, so make sure that you identify all those causes and put corrective actions in. And we ask you to submit confirmation when you complete that investigation. The Good Practice Guide is from the Council of Europe, and it states that the quality system in place in all blood establishment complies with good practice guidelines and with the standards and specifications set out in the annex of that directive. In other words, the Good Practice Guide exists to help implement the requirements of the blood safety and quality regulations. Some of the key points from the Good Practice Guide is that an appropriate level of root cause analysis should be applied. If the true root cause cannot be determined or identified, consideration should be given to identifying the most likely root cause. Also, very important, when human error is suspected or identified as the cause, this should be justified, having taken care to ensure that process, procedural, or system-based errors or problems have not been overlooked. Because what we want to do is to improve our systems rather than blame individuals for their part in the error that's occurred. The effectiveness of these corrective actions should be monitored and assessed in accordance with quality risk management principles. Further details about incident reporting, identification of root cause are found in Chapter 9 of the Good Practice Guide. So common problems with SABRE reports that I've noticed is often that the notification report is delayed. As I said before, the requirement is to report as soon as known, and our expectation is that we get that report within 48 hours. And those reports are shared with SHOT immediately. Often the notification report doesn't come until after the investigation. As I said, that's not in line with regulations. We need to know the notification as soon as known and not once you've finished that investigation. Often the confirmation reports are also delayed, and sometimes that's because of trust-wide serious incident investigations delaying the reporting unnecessarily. You're reminded that reporting to MHRA and SHOT is a legal requirement under the blood safety and quality regulations, and that takes precedence over local trust reporting. Delays in reporting can result in failure to remember detail of the incident that's occurred, loss of any witness information, and that increases the risk of repeat errors. And if it's not reported to MHRA and SHOT, it lacks the scrutiny and input from the haemovigilance experts. Often we see a lack of detail where incidents are poorly described and written. Sometimes the reports can contain only the conclusions. In other words, we need to understand how you've reached those conclusions. It's a bit like a maths problem where we need to see you're working out. We often see a lack of depth to the investigation. The root cause doesn't go beyond identifying human error as the cause. And as I said before, this overlooks any system failures. All this together increases the risk of repeat errors and potential harm to patients. Other problems with corrective measures is that they don't identify the root cause. It places unnecessary responsibility on an individual for an error made, and improvements to the quality systems are not identified. Sometimes the corrective measures are incomplete. So the requirements are to address all causative factors. The use of reflective practices should not be part of the corrective action plan, but form part of the investigation itself. These self-reflections are ways of identifying the human factors involved that affected the way that the individual behaves at the time, and shouldn't be used as a form of punishment or corrective action, but used as part of the investigation. You need to ensure that all elements of the process, documentation, training, environment, staffing, workload, distractions, etc., are improved before concluding human error. Don't leave corrective action unfinished. For example, committing to review an SOP is not the same as reviewing an SOP and rewriting it. We also see during inspections the reflections from incident reporting, and many of the common findings of inspections are that the root cause and kappa did not adequately reflect the potential harm. The incidents review showed insufficient evidence of an appropriate level of root cause, no justification of the late closure of incidents, and no formal process for extending investigations and associated impact of risk assessments, and no justification for allowing for the allocation of incident investigation and closeout times. Many SABRE reports are not made as soon as known, and there are no detailed trending of incidents. So at the bottom of this page, you can see references to the good practice guide. And so the experience of myself in SABRE and the inspectors are, we find similar deficiencies in reporting. And that's all I have to say. Thank you for your time. And I now hand over to Emma.
Thank you, Chris. So I'm just going to start discussing some insights from SHOT over the years around human factors and ergonomics. Next slide, please, Nikki. So these are some of the common themes that we see from analysed SHOT reports. And you'll see that many of them involve IT, which Jenny will expand on much more later. And IT systems have been shown to improve transfusion safety and efficiency, and also provide barriers to errors caused by human factors. However, it must be remembered that IT systems don't replace the knowledge and skills of healthcare staff. Next slide, please, Nikki. And often we hear about the dirty dozen. These are factors that contribute to errors in healthcare, and these can be compounded by staff shortages. I'm sure some of these factors will be familiar to some of you watching. And these recurring themes in the serial SHOT annual reports and a high incidence of preventable errors prompted the human factors and ergonomics work from SHOT. Okay, so what do we mean by human factors? Well, a definition is that human factors is the scientific discipline concerned with understanding of interactions among humans and other elements of a system. Human factors, also referred to as ergonomics, is an established scientific discipline, and it's used in many safety critical industries such as healthcare, airlines, and oil. Next slide, please, Nikki. And human factors encompasses all of the factors which can influence the behaviour and performance of human beings within a system. It allows us to understand how people perform under different circumstances and why errors happen. And human factors shouldn't be mistaken for being about the human themselves, as there are multiple environments, types of equipment, technology, and critical steps in the transfusion process. Next slide, please, Nikki. So consideration and investigation of human factors has been shown to lead to reduction in errors, waste, risk, increased engagement and well-being, all which can help to improve patient safety. And must remember that human factors is not the same as human error. This is really important to recognise. And this slide is quite a busy slide, so bear with me as I think it does actually offer a great explanation. So when human error is involved, the occurrence of human error implies that it can happen again. And we all know human error is actually inevitable. But if one well-intentioned, competent member of staff is making a mistake in their typical work environment, that shows us that perhaps system factors have facilitated that error. And an important question to ask yourselves is, could another member of staff make that error? And our goal as part of learning from incidents is to increase safety in the long term and not allow a similar event to occur. And we find that solutions that are only people focused are often weaker solutions, as they don't address this probability that the event could occur with other staff in similar circumstances. So it's therefore important to understand the system factors facilitating human error and develop solutions to those systems. Our language affects the way we view the world and how we approach problems. And if we wish to understand how systems really work and improve how they work, we need to enrich our vocabulary with systems concepts and use them in preference of simplistic terms that don't help explain how systems actually function. So in transfusion, human factors principles are important in all of these aspects: designing policies and processes, work instructions and equipment, training, safety, culture and environment, and also obviously investigating when things go wrong. So I'd just like to run through the SHOT human factors journey so far. So in 2013, in the annual report, SHOT made its first human factors recommendation. And in 2014, SHOT began a collaboration with Loughborough University to help improve safety of transfusion processes across the UK. In 2015, an exercise was carried out reviewing past SHOT cases using various human factors models. Some of them you may recognise, such as SEEPS and AXIMAP. And then in 2016, SHOT introduced its own bespoke human factors investigation tool, or HFIT, as we abbreviate it to, because it was found that no model was ideal for transfusion incidents. So in 2017, data from the HFIT did demonstrate overemphasis on blaming staff for incidents. So a self-tuition package was developed to help understanding of human factors for reporters. And in 2018, we did show that there was a slight reduction in staff blame, but also to enhance learning, we've since developed a whole suite of resources and also a dedicated human factors page on our SHOT website. So to 2019, we can see that because of the combined use of the learning package and some of the resources, you can see a clear continuation of reduction in staff blame. And in 2020, there was publication of the PhD thesis in collaboration with Loughborough, and we have Alison Watt coming up who will describe that in a lot more detail. So in 2021, we published the final analysis of 5 years of the original HFIT, and we decided to make some amendments, and we then amended the HFIT and based it on the Yorkshire Contributory Factors Framework. And as you can see from the graph at the below, we demonstrated a significant decrease in the allocation of staff blame, which was incredibly encouraging. And in our latest annual report that we published a first analysis of the new HFIT, which again showed a reduced culture for blaming staff and more recognition of system and organisational factors, which again, incredibly encouraging for us to see. And we should acknowledge the contributions of our predecessors, whose hard work, commitment and perseverance has brought us to this point. And safety is all about collaborations, networks and relationships, and richness of discussions and outputs from SHOT is only because of the valuable contributions from all our many collaborators and the wider transfusion community. So how are we continuing to promote use of human factors principles in transfusion? We have our human factors chapter in the annual SHOT reports and also tooltips on our website. As I said earlier, we've developed a whole suite of resources, including SHOT bites, videos and shotcasts. We've had webinars such as this one, which you can find the recordings of if you didn't catch those live at the time. We have a human factors course, which we've run virtually so far and are going to do a live one, a face-to-face one, sorry, at the end of the year as well. And we're currently seeking accreditation from the Chartered Institute of Ergonomics and Human Factors for that course. We've had some prominent speakers at our annual symposiums. And we've also demonstrated enhanced learning by applying systems to human factors principles. And last year, we were absolutely delighted to be shortlisted and actually win the category for the Harnessing Human Factors approach. So this photo was taken at the Health Service Journal Awards last year, and that was a real kind of validation of all the work that SHOT have been doing. And in the 2021 report, we made the recommendation, which is shown there. We're in the early stages of analysis of that recommendation survey, and this is already looking very encouraging. So we can see that a high number of lab areas are either working towards or have already got this recommendation in place. And likewise, clinical areas are really making good progress. So a reminder of some of the human factors SHOT recommendations. So staff investigating incidents should be fully trained in techniques for effective incident investigation. Investigation should identify and include improvement actions, and also the 9 key principles outlined in the white paper, learning from adverse events, should be applied to investigating incidents. So to finish, some key messages from the human factors and ergonomics analysis in recent SHOT reports. One of them is attribution bias. So incident investigators should analyse all the evidence as impartially as possible. Incident investigations need to incorporate questions using human factors principles. To avoid missed opportunities, systemic causes need to be identified to build robust long-term solutions. Staff should be trained in basics of human factors and have access to experts. And staff are encouraged to participate in human factors-based face-to-face audit. Thank you very much, and I'm going to hand over to the next speaker now.
Thank you, Emma. I'm going to cover the overview of incident investigations key principles. Why investigate incidents? Mitigate the impact of incidents and identify contributory factors. Identify strengths and weaknesses in the processes, makes improvements to processes, learns from mistakes and victories, builds future improvements to the QMS, and ensures patient safety from a robust QMS and safety component. It is not to blame individuals for the errors that they've made. Incident investigation covers the following aspects: an initial assessment, what went wrong and why it went wrong. And remedial actions is to take actions immediately to ensure that the risk is minimized. Ask yourself, is the patient safe? Is the future patient safe? And does the service need to be suspended? What can be done to make the patient safe during the investigation? I will now hand over to Alison to carry on the presentation.
Hi there, yes, and apologies also that there aren't any captions on the slides. Apparently the elves behind the scene are working on this. So I'm going to look a bit at the investigation process, but particularly from the point of view of applying human factors principles to the systems thinking, so that we can look at all of the background in an investigation. So this is just a quick run through of what the investigation process should look like. And you can see that we've highlighted in red there that you should apply human factors principles and systems thinking when possible. And I'm hoping that if we move on to the next slide, that'll take us just for a quick look at some of the systems, some of the human factors models that are available, including the Yorkshire Contributing Factors framework, in which our human factors investigation tool is now based. And then I'm hoping that if Nikki presses it again, it'll take me back to where we were. Oh yes, brilliant. I love it when a plan comes together. So that we can then look at this and identify what practice has either gone wrong or in some cases has gone well, even within an incident. Learn from that, and particularly then put in the corrective and preventative actions and smart actions, which I'll talk about a little bit later. And when you've done that and reviewed it and check everything's working, the next bit is the learning and sharing and making sure that all of the information gets passed on, not only within your own department, but elsewhere within the organisation, and then moving on beyond that. So one of the best models that people are using, particularly in healthcare, is the SEEPS model, Systems Engineering Investigation for Patient Safety. This is what the pretty model looks like. It basically is just saying it's all about system orientation, it's person-focused and design-driven. I think if we press again, we get that written out a little bit more simply. So it's one of the available systems, and when you've looked at all of the systems, you can then make recommendations that are targeted at the system and not at the person. And it can have a very positive influence on the safety culture in the organisations. And also, just to say, there was a link on there, which is to a very good paper. And I know we are rattling through these slides at a breakneck pace, but if you go back over it on the recording, you can see there are lots of links there, and there's a load of background work, including the stuff on our own website. And this, sorry, can we just nip back to that one? So this is some work that was done by Stephen Shorrock, who's one of the best human factors investigators. It talks about the difference between how you think work should look and what actually happens at the coalface. So if you think about it, it's a bit like the difference between what's written in an SOP and what you actually do when you get into work and you find you haven't got enough staff or you haven't got enough facilities to do the work. So if we move on to the next one, it's just more simply, you can define this as the difference between work as imagined, which is what the designers and the managers and the regulators and everybody else thinks should happen. They probably believe that is what actually happens. But work as done is what is happening to get the job done. And so it's what's actually happening on the day-to-day. And a good example of this in transfusion is you could have a policy that says, take the patient's details to collect blood. And most of us would think that's probably enough. But then when you think about it, all of these options on the right-hand side of the slide are take the patient's details to collect blood. It doesn't actually tell you how to take the details or what to take. And probably none of these are suitable. And the quick, smart-eyed of you will notice that actually all of those are different. So the different spellings of Sarah or someone or date of birth or whatever, and that's exactly how the mistakes start to happen. And that's a huge difference. So we're looking at needing to plug that gap between the work as imagined and the work that's actually done. What's happening, when you've bridged that gap, you can then understand how the systems are working and where mistakes are likely to happen. And your incident investigations will very often pick those up. So when you're looking at putting in the actions when you had an incident, it's very important to have SMART. I'm sure most of you are familiar with this, but specific, measurable. There's no point putting in an action if you can't actually measure that it's been done and that it's actually making a difference. Are the actions achievable? And this can be sometimes a problem because you may want to put long-term actions in, such as we really need a new IT system. And people shy away from that because they think they're not achievable. But if you never try to put that action in, it will never happen. Obviously, it needs to be relevant, although just a slight word on that one as well, that when you investigate incidents, you do often find other things that are going wrong in the background, the kind of minor things almost of like maybe the paperwork wasn't filled in properly or something like that. And don't forget to deal with those as well, even if they haven't actively caused that incident. They're sitting there waiting to cause the next one. And of course, it has to be timely done in a time frame. So let's put this in context. On the right that's the easy action. You just put something like, oh, we need some training for how to respond to the fridge temperature going out of a line. And so we'll include it in the next training. We'll do it sometime in the next 6 months and someone in the transfusion lab will do it. And you really know, actually, none of that's going to happen. Best case scenario is someone reviews that in 6 months and goes, oh, we never got around to that, did we? Whereas on the left, the good action is they're creating a training plan. They're going to make sure that the target date is a short target date, and more particularly that any staff about to do any lone working are trained. They've got a specific person, the lab manager, to do it. And they've actually put in evidence. They're going to want to see signed training and competence assessment. Those are pretty much the same actions, but far better, the SMART one. And also looking at what is the most effective action that you, intervention that you're going to put in. So not only SMART, but it has to be effective. And this is a simple idea of which are the most effective. But if we go on to the next one, and again, there's links there for loads more information. The most useful intervention is some kind of forcing function, something that you can't get past without doing the right thing. It's actively stopping you do the wrong thing. The next on the hierarchy is something that's system focused. So it at least is standardizing protocols or putting in a robust checking system. And these are actually very good as an interim measure while you're trying to get the new IT system that you know is going to take years. At least look at the system and get something pro-tem in. And the weakest ones are sadly the easiest ones to do, which is people focused. And of course, education and training is needed, absolutely, and changing the rules and policies. But even if these are applied to the whole team rather than individuals, they are known to be ineffective, and they might be easy to implement, but they're probably not going to stop the next incident happening. So they're a good first line of defence, but don't forget the more effective ones as well. So having an idea of what is a forcing function, so it can be an aspect of design that stops you doing an action without consciously considering it. And this is particularly useful where you've got things which are automatic. Thinking about driving a car is a good one. And it's why a safety gate at a railway crossing is always going to be far better than a railway crossing, and just hope that the driver notices it. You can't go through. And it's about an aspect of a design that prevents you doing something that would actually be unintended or certainly undesirable. And then these are particularly useful in safety critical work. I mentioned railways, which is a very obvious one, but you can think of it day to day. You can't start your microwave without closing the door, because you don't want those microwaves coming out into your kitchen. When you go to the websites, we all hate this, don't we? But it stops everybody using the word password as their password if it tells you you have to have a capital and you have to have a number and you have to have a symbol. So those are the sorts of forcing functions. And I think we've got some examples in transfusion on the next slide. So it's things like the limbs preventing the release of ABO incompatible blood, things like blood fridge that has an electronic lock, and only people that have got the training can actually access that lock. Hemobanks that will only allow clinical staff access to either the emergency O units or to a unit for the patient with a pickup slip, or blood fridges in the first place that won't open to accept a unit without making sure that the label verification is the same as the label on the bag. So those are good examples. And this is a very busy slide, and I'm not going to try and go through the whole thing, but these are really useful tips of where you can make your interventions more effective. Let's go on to the next one. Yeah, because then the next important thing is you need to review the effectiveness. So you've now done your investigation, you've got your smart actions, you've looked at the higher end of the hierarchy of interventions, and then to close the loop, you go around it and check it all with things like audit or checking people's knowledge, doing questionnaires, or monitoring near misses. And we've got a couple of slides talking about near misses coming up. And near misses are free lessons. You're catching things before it does any harm to anyone. And the classic one in transfusion is wrong blood in tube, which do get caught most of the time, but of course not always. But you get far more lessons from the near misses, we hope, than from the real incidents. And an organisational culture that values near misses is a highly resilient organisation. Very often, people will say, "Oh, it was a near miss. Patient wasn't harmed. We're not reporting this. We can't do that." But the high resilient organisations, such as the air traffic controllers, look at all of the near misses, because near misses to them, what we would call a near miss, they call an incident, because for them a near miss is a plane nearly hitting. But they look at all of their tiny little incidents because you don't want your plane to be hitting in the sky. So I think, oh yes, this QR code is to the HSIB work that was done on wrong blood in tube. So you're probably aware of the Healthcare Safety Investigation Branch, and they take a serious incident and then look at all of the aspects of it. And this is a really good one on wrong blood in tube and learning from near misses. And then, as we mentioned before, the important thing is to share the learning, obviously back to the individual or individuals involved, because there's nothing worse than that, having something happen, you don't know the outcome. Share it widely in your organisation, but also nationally and internationally, of course, sharing with SHOT and MHRA and doing things like this. This is what we're doing, sharing international. Hello to our international people on the call. And then this again is a busy slide. I want to stop on this first one if I've caught Nikki in time, because I'm going to say about this one. I think if you only take one message home from this, can we stop concluding human error as the outcome of your investigation? Very often people will jump straight to, oh, it was just that idiot that made that mistake. And what we're really trying to do is get people to understand that the human is only going to make the error because of all of the system problems. If the human has not made an error, if they've made some kind of dramatic sabotage. They've deliberately given the wrong blood, or they've deliberately done something awful. That's not an error. So you can't call that human error. If they've made an error, then almost certainly that error is going to be down to something in the system. Even if it's something directly related to the human, it will be about the human hasn't had enough training, or they were in a bad situation, or whatever. We'll put up the rest of these, which are good warning signs if you've got a suboptimal incident investigation. So we're now sort of like at the end of an investigation. Just go back over your investigation and think about, have you checked everything in the process? Have you investigated all of that? Have you done it with a systems viewpoint and understood all of the contributing factors? Have you looked at whether the interventions are smart and they're getting near the top of the hierarchy of interventions? And then look at the impact of what the outcome of your investigation. And I think that might be the end of mine. And I'm passing back to Karen, who's now going to put this into context for you.
Thank you, Alison. We're now going to cover 3 cases that were reported to SHOT. We're going to start off with case 1, which was ABO incompatible platelet transfusion, which was given to a patient. And if you look at the scenario, it was a unit of platelets that were requested for a non-Hodgkin's lymphoma patient with critical site bleeding. The laboratory staff issued group O platelets by accident for a group A patient. The ward staff completed the pre-transfusion checks and transfused the unit. Later, the error was identified by the laboratory staff. The ward was notified and advised not to give the unit, but it had already been transfused. The biomedical scientist who issued the unit was experienced, but was new to the laboratory, and they assumed that the platelets needed to be taken from the top shelf. The LIMS system flagged that the group O platelets was being selected for a group A patient, but the BMS overrode the warning. The biomedical scientists could not explain why they had issued the mismatched platelets, but it was discovered that although the BMS had almost completed their competencies, they had not had a competency for issuing components. The patient fortunately did not suffer any harm. However, when we look at the incident in depth and we avoid blaming the individual involved, there were a couple of aspects that were raised during the incident investigation. First of all, from the staff perspective, the incident occurred during the night shift. There were workload issues identified in the laboratory on that night. And again, as said in the incident, the BMS had not been competency assessed to issue components in that particular laboratory. From an environmental perspective, the layout of the platelet storage area wasn't clear to the BMS, and there was an assumption made where the platelets were positioned. From an organizational perspective, the BMS was lone working on a night shift, and there were identified system and communication failures. From a government or regulatory perspective, there were insufficient NHS funding, leading to the inability to increase staff levels to be able to cope with increased workloads and changes in work patterns. Our second incident covers a delay in urgent transfusion caused by a lack of labels in a remote refrigerator printer. A gentleman with gastrointestinal bleeding came to theatre shocked with hypertension and tachycardia and had a hemoglobin of 70 grams per litre. The staff had to wait for the transfusion laboratory to come to theatre to put the labels in the printer. The second telephone call was made by the anaesthetist, who said they now needed somebody to come urgently. It was supposed to send a remote alert when it reached a low when the platelet printer reached a low threshold of labels. He was eligible for a remote issue, but the staff were unable to release blood from the electronically controlled refrigerator as there was no paper in the printer for the compatibility labels. During the first phone call requesting help, the staff were told that the transfusion laboratory staff were in the middle of a handover and couldn't attend immediately. The label printer does not generate a local nor a remote alert when empty and was designed to count a specified number of printed labels. Also, access to the printer was open to anyone and is easily knocked and resulting in a misalignment of the feed. When we look at case 3, sorry, Nikki, we go on. When we look at case 3, which was an avoidable platelet transfusion following a Wibbit, when this incident was thoroughly investigated, this was a gentleman in his 50s who was transferred from another hospital, but he actually moved between hospitals and also moved between departments within hospitals. This investigation was thoroughly investigated by the teams involved, and he later received 3 units of platelets from an apparently low platelet count. This was identified 5 years later when before and after showed a huge discrepancy in the levels. The blood group results were consistent ones, but the hematology and biochemistry results suggested that they were from a different patient. As I said before, this was thoroughly investigated as a wrong blood in tube incident in collaboration with the department involved. The transfusion practitioner worked closely with the emergency department. Sorry, next slide, please, Nikki. They worked thoroughly with the investigation with the emergency department and detected that the error occurred in the ED by a phlebotomist. The sample process was mapped out by the transfusion practitioner and the staff in the emergency department, and was found that the COVID-19 restrictions impacted on the flow of sample taking in the department. This raised an awareness of a wrong blood in tube across all the teams in the organization and resulted in the educational package and training being updated with these issues. Cognitive bias is a source of errors. Cognitive bias places limits on the mind's ability to process information, causing the brain to make assumptions and drawing conclusions from these assumptions. They are, in effect, our unconscious thoughts. They are shortcuts used to aid our decision-making and can contribute to errors in healthcare through various measures. There is a link in the box on the right, which you can access more information on this. Cognitive bias are due to the way the brain perceives, forms memories, and make judgments, and impacts on the way that we behave. Factors which have a potential influence on cognitive bias increase the likelihood of this and can be divided into the following factors. Patient factors, for example, a complex patient. Person factors, for example, fatigue. And system factors, for example, noise or distractions during a shift. I'll show you a case study coming in the next slide, which shows cognitive bias. This is a case study of a young patient in mid-20s who received 2 units of fresh frozen plasma and 2 units of cryoprecipitate out of hours instead of 4 units of FFP. The cryoprecipitate was stored in the wrong location in the freezer, and the staff failed to check the components prior to thawing and issuing, assuming that all the components were FFP. The staff collecting the components and administering also failed to identify the error, and this was only noticed by the laboratory staff the next day. Safety culture is a term that we all hear about these days, but in my opinion, it actually demonstrates an ownership of safety across the entire organization and at all levels. It reflects the mindset of the organization, its people, looking at how their values, beliefs, and influence the way healthcare and safety procedures are implemented and used. For example, a reporting culture is where staff feel readily empowered to report problems and errors and near misses. A just culture where they are encouraged to report safety-related problems. A flexible culture is an organization that adapts to the changing demands while still focusing on safety. A learning culture where there is a willingness and competence to draw the right conclusions from safety information and a willingness to implement them. And lastly, a questioning culture where staff feel free to ask the what ifs and why questions, which removes the assumption option. It is about asking what happened and why, rather than who made the error. But how do we create a safety culture? For this to happen, it's important for organizations to move from a psychological danger setup to a psychological safety setup. Staff should be encouraged to report incidents by managers and leaders through learning from incidents, incorporation of gratitude into incident investigations, avoiding blame, and using inclusion principles. We all know that prevention is better than cure, but of course, we would rather not have any patient harm in the first place. This is why it is so important to thoroughly investigate near-miss events, have detailed risk assessments and robust processes in place, and that cover every aspect of a task or process, while simultaneously having a good safety culture that encourages suggestions for improvement and raises potential risks with management that listens and responds. I will now hand over to Dr. Jenny Davis for the next part of the session.
Thanks, Karen. Yeah, so the UK Transfusion Laboratory Collaborative was formed back in 2006, and that was in response to the number of wrong blood events and errors that were occurring in hospital laboratories. And the collaborative includes a number of organisations that you can see on this slide here. And we also have a page on the SHOT website where we keep some useful information and resources that you can access. And the UKTLC published recommended minimum standards for hospital laboratories. And these standards covered staffing, qualifications, and IT. And they aim to give labs a baseline for provision of a safe transfusion practice. And we've updated these standards in 2023. They're not actually published yet, but there is an abridged version on our webpage, along with a gap analysis tool that you can use to look at your own compliance. And also in 2022, we released a survey looking at current transfusion laboratory practices, and a summary of that will be available on the website as well soon. So I'm just going to spend the next few slides looking at each of the standards, how they can be used, both in incident investigation, but also as a preventative measure to errors, and also having a look at what the survey results showed in relation to this as well. So standard 1 covers staffing, and this includes staffing numbers and skill mix that's needed for the lab to provide a safe service. And we do know that errors occur when staffing levels or skill mix are inadequate. There's no magic formula, I'm afraid, for working out how many staff you need, because it's different for each lab and depends on things like your level of automation and your workload and specialist work, etc. So each lab needs to have a capacity plan that's unique for them. And we have guidance on our webpage on how to create these. But what's important is it's not just the testing and the blood component provision that's included in this plan. You also need to build in work required for the quality management system and training and supervision of staff. And you need a process for monitoring compliance with the staffing numbers and escalation when you're not meeting the appropriate numbers and the skill mix. And this will obviously help trying to prevent errors in the first place. And when investigating incidents, always look at the staffing levels at the time of the event. Were they in line with your capacity plan? If not, then is this just a one-off, or is this happening all the time? Have you got your capacity plan correct in terms of numbers? Are you escalating when you should? And are you getting support from management? And it's important to recognise in the incident report if you are short-staffed and what's being done about it, even though you know that this probably isn't going to be a quick fix. So the survey results showed that there were a good number of labs that had capacity plans compared to the previous survey. So this is good that this is picking up. But it also showed us that labs are struggling with the lack of compliance with their capacity plans in both staffing numbers and skill mix. And in the survey, we also asked whether labs were carrying vacancies. And this is a question that had also been asked in previous surveys and included any vacancies that were currently filled by locum staff. And you can see from this slide that there was a big increase in the number of labs that said they were carrying vacancies in 2022. So we're seeing that labs are really struggling with staffing, and this is obviously going to impact on the ability to provide a safe service. Standard 2 covers the qualification, knowledge and skills of the staff, and SHOT data consistently shows that errors occur due to gaps in knowledge and training. And this standard also describes the qualifications that are appropriate for staff working in transfusion in order for them to have the knowledge to do their job. And if staff don't hold any of the recommended qualification, then we do give on our webpage guidance for local risk assessment and benchmarking against those qualifications. And the standard also covers the requirement for regular practical and knowledge-based competency assessment. And we asked about the compliance with the qualifications in the survey and whether staff working unsupervised had the appropriate qualifications and experience as stipulated by the standards. And if they didn't, then why was this the case? And we had 51 responses where the staff didn't comply with the standards. And this was mainly because the staff were either working towards the standards at the time, or they were multidisciplinary and so didn't have transfusion specific qualifications, or they had a local equivalent training to meet the standard. And we also asked a question about whether the ability to train or mentor inexperienced staff had altered during the last 2 years or for 3 years in the 2022 survey. And we asked if this had remained the same, become easier or more difficult over the years. And as you can see in 2022, there was quite a jump in the number of respondents saying that this has become more difficult. So also when you're doing your incident investigations, do build in a review of the qualifications, the knowledge and competency assessment of the staff involved. And if the staff are lone working without holding one of the recommended qualifications, does your local training cover the equivalent knowledge? Does the regular competency assessment programme adequately cover the knowledge and skills to do the job? Did the staff receive all the training? Are they up to date with their competency assessment? And if not, is this the case for other staff as well? Is there a wider issue around training and competency assessment that needs to be addressed? So standard 3 covers IT, and this includes analyzers, LIMS, and electronic blood management systems. And we do know, it's been said in this talk already, that IT supports safe transfusion practice in the lab and in the clinical area when it's configured and used correctly. And we saw it's at the top of the intervention hierarchy. So you should be looking to use it whenever possible. And in the survey, we did ask this question about the use of electronic blood management systems. And you can see in this slide that despite the use of these systems being recommended by SHOT since 2017 and plenty of publications supporting their role in patient safety, still about 30% of hospitals don't have them in place. And only 16 of our respondents had full vein-to-vein systems in place, including the cold chain sample collection and administration. So in your instant investigations, do look at the impact of IT. Did IT actually cause or contribute to the error? And if it did, has it been set up correctly? Do you need to make some changes or improvements? If errors were in manual testing, could this be moved to an automated platform to make it safer? Have you got your IT systems interfaced, or would interfacing reduce the risk if you could actually achieve this? And review your LIMS functionality. Could it block errors, as we talked about earlier? And are the flags and alerts appropriate and understandable? And we do know, all of us, that changing or implementing IT is not a quick fix, but do raise it if it's appropriate as an improvement action from the instance that it goes on a roadmap. And if it's relating to an IT system that you currently have in place, then raise it with the supplier so that they can put these improvements on their development pathways as well. And in the 2023 standards, we've incorporated a new section on just culture. And we know we can only learn and improve if we have a culture where staff are encouraged and feel safe to report errors and near misses, where they can make suggestions for improvement and raise potential safety risks before they happen. And on the other side of the coin, we also need to be able to learn from examples of excellence and how we can incorporate those into routine practice as well. And this all needs to be led by management. And we asked about this in the survey, and it was encouraging to see that nearly all the respondents felt that they did have a just culture in their lab. But we also wanted to know about how and where human factors principles were included in practices. And you can see from the bottom chart, there's mainly within instant investigation, which is really important and really good to see that. And some labs are also incorporating it into other aspects, including implementation of new processes, evaluation of the current practices, new equipment and staff training. And it would be really good to see an increase in those areas as well. And having this culture in the labs and using human factors in process design obviously enables us to proactively make improvements in the system before an incident occurs, rather than waiting until something happens and then we're having to react to that. So over the next few slides, we're just going to look in a bit more detail about IT and transfusion and what we're learning from SHOT reports. So back in 2019, the SHOT IT Working Expert Group looked at themes within error reports and created this infographic, which you can access on the SHOT website. And although this is a few years old now, the same themes still apply today. And we see errors relating to IT across a wide range of SHOT reporting categories, as you can see in the pie chart. And this really reflects the increasing use of IT in healthcare. But the majority, as you can see, relate to the failure to provide blood components that meet the specific requirements of the patient. And in the table on the right, you can see the errors mostly relate to failures in flags, alerts, and logic rules in our IT systems. And this can be that they're not there at all, they're not updated, or the flags and alerts are overridden or ignored by the users. And this is why it's worth reviewing IT in your instant investigations, because this is where you can make a really big difference in reducing errors if it can be configured correctly and if the alerts are appropriate and not easily overridden. And SHOT has also repeatedly demonstrated the persistent adverse safety consequences of the failure to achieve interoperability between our IT systems. And this is becoming increasingly important now as we're seeing more IT systems being used in our hospitals, including electronic patient record systems. And we need to look to harness this interoperability to remove or reduce the human element of data transfer, which we know can cause error. And I mentioned flags and alerts earlier. And when we look at this from a cognitive bias point of view, people can get overwhelmed by multiple alerts. And so they're less likely to pay attention to something that's repetitive and is frequently overridden for different purposes. And this is called alert fatigue, and it has the potential to cause errors and impact on transfusion safety. And this risk is reduced if these alerts can be transformed into relevant and actionable intelligence. And the alerts need to make sense to the user, and they need to enforce a justification to be entered as part of the override, which makes people think about what they're doing, not just a click escape to continue type of approach. And a structured proactive approach is suggested to address this by using the principles shown on this slide here. So over the next couple of slides, we've got some case studies to look at which involve IT. And in this first case, the unit of red cells was given to the wrong patient. So the correct unit for the patient had been collected, but the nurse took it to the wrong patient on the ward. The nurse was using an electronic tracking system for administration, but this lost its power partway through the checks. And instead of reverting to a double independent check as per the local policy, the nurse continued on their own and put up the unit, failing to notice that it was actually labelled for another patient. And this was noted by another nurse on the next shift. And luckily, both patients had the same blood group. And this demonstrates really an over-reliance on IT to do the checks rather than the individual. So the IT should be the second checker. It's your safety net, as it were, to pick up any errors. It's not the first line check in these cases. And when IT is not working, which we all know does happen, we need to make sure that we've got robust contingency plans and everybody knows what they are. And also this case really shows that we need to look after our equipment so that it works when we need it. So an important message, I think, is when you're looking to implement IT systems to solve your current manual process problems, do be aware that IT will give you new challenges and you do need to be prepared for those. So in this second case, the BMS received a request for 2 units of red cells for a patient with known antibodies, anti-little e and anti-big C. And the BMS noted that the patient was in the childbearing potential age range, was RHD positive, and so according to the local policy, should have little c negative, big E negative red cells, which is the opposite to the actual requirement for big C negative, little e negative. And the LIMS alerts were in place to let the user know, but not at the point of issue or reserving of the red cells. So unfortunately, incompatible red cells were selected, they were cross-matched and transfused. So this is really complicated, isn't it? There's lots of things to consider for this patient that were at odds with each other. But there were some things that went well. With this, we can see some good practice here that the local policy had actually considered the potential of patients to make anti-little c, which can have significant effects on the fetus in subsequent pregnancies. And the BMS did note this as well. The LIMS did flag to state the antibodies and the units were serologically cross-matched. But there's also some learning points here that we can see. We can see that assumptions and cognitive bias can have serious consequences, as they did here. The IT did alert, but the staff overrode it. So were the alerts not clear enough? Does it clearly state to the user what the problem was and what action they should take? And if the alert was only at the start of the process, then this might be by another member of staff to the one that's actually doing the cross-matching. So the alert's not at the appropriate part in the process. So what would we suggest as corrective and preventive actions? So to make the alerts clearer, in an emergency, you might need to release red cells that are not antigen negative. So you can't put a hard stop in here, but a warning should give clear instructions to the user. Obviously, make sure the alerts are at the right stage in the process and educate staff on cognitive bias and its influence on behaviour as well. So thank you. I'm going to hand back to Shruti now.
Thanks very much, Jenny. And this is the last part of the presentation, and we will take questions after this. And what we have been really talking about is actually how do we respond to the safety incidents that happen? And that is all the safety one, which is actually the classical way. And what we are really trying to also say is how can you make every experience count? And this is also actually bringing into the picture the safety two, or the proactive approach. So what we really need is both of these approaches to actually ensure a holistic approach to safety, so that we are actually learning from all the instances that are actually happening in healthcare. So if you go on to the next one. So you're all familiar with this curve in one form or the other. Lately, there are lots of actually papers since Professor Eric Hollnagel's paper on bringing safety to. So, here you can actually see the safety one aspect is actually focused on the red box here. This is only at one end of the spectrum when things have actually gone wrong. And we know very well that, majority of the instances, things go right. So how can we actually then optimize the learning? And when you talk about safety two, you're actually then ensuring that you're learning from everyday actions and outcomes as well. So you're looking at what are the risks, what are also the opportunities for the learning. So it is actually, optimizing the opportunities for learning across the spectrum. And now in the, this is similar to, if you want to actually learn about sharks, you can't actually just focus on the shark attack. So Nikki, if you actually press that, this is actually the, a statement which is attributed to Bob Weers, a patient safety specialist. So he actually then said, trying to understand safety by only looking at incidents is like trying to understand sharks by only looking at shark attacks. So we are really trying to actually promote a holistic approach to safety. Now, towards that, you're all familiar with the short ACE category that was introduced in the last couple of years. And this is essentially a form of learning from excellence. And this provides you an opportunity to actually submit the cases. And we are trying to actually create a ripple effect so that people are actually then incorporating it into your local practices as well. And using appreciative inquiry, using the right language, open-ended questions, and positive reinforcement. And it is actually optimizing the learning from these reports as well. And one of the examples are, this is actually the very first thing that we actually got out. So this was a case where there was a full power outage in the UK hospital. Everything was disconnected, and even the backup also did not actually work. There was no telephone system as well. But how did staff manage in such a challenging situation? Now, this was actually out, I think, for a couple of hours, and they still needed to actually supply blood components for a couple of patients, and the staff went over and above, that too when even the contingency was actually gone. So this then prompted us to actually issue a safety notice to the hospitals. This is actually just to ensure sharing the learning across the UK. But it also actually tells us, while people may have greatics and other different forms of actually reporting, that and celebrating success, what we are also needing to understand is how can we actually learn, and how can we distill the intelligence from these reports? What happened in that instance? Can we actually mimic that? And can we actually then ensure that we have more of such reports? That is what we are actually then on the journey to learn more about. And we do have a separate ACE reporting page on the SHOT website. So if you go on that, we have links to all the guidance, the chapters from all the recent reports and the various examples. And we do hope that, all the transfusion teams, clinical and laboratory teams also would be actually then promoting this within their own system as well. So thank you. So when you remember again that curve, on one end was learning from incidents, learning from excellence is at the other end. And what we are trying to actually then promote is miss no opportunity. So what is actually the bulk of the events that we actually then happen day in and day out? How can we learn from everyday work? So this is known to improve all aspects of performance and well-being. It does not wait for an unwanted event to happen. So, as is mentioned, majority of the instances, it goes well. You may have some workarounds, but still the outcome is actually then nice. So it also then helps us to, detect any kind of a change that is actually happening on a day-to-day basis as well. And also can actually then see the slow changes that are helping evolve over day. And also the important thing is we are involving everybody in the system, not just a few people who may be involved in the incident investigation. So you can see there are lots of advantages to learning from everyday work. And most of us actually then, there are different ways in which we can learn. That comes in a future slide as well. This is a paper from Stephen Shorrock again, where he was exploring about how can we operationalize the safety too. And essentially what they actually say is there are, if you look at the skills and the attitudes that are necessary, you should be able to ask good questions, listen well, take multiple perspectives so that you have the diversity and inclusion in your thinking as well, and decision making. And you need to have that willingness, the curiosity, and the humility. So it makes it, all the more that, okay, these are prevalent. We can actually use these to our strength and optimize learning from day-to-day events. So now this is actually the QR code, but as mentioned in the chat as well, we will try putting all these links and we will put the PDF of the slide so that people can access that when the webinar recording goes live as well. So what are the other safety tools? I just wanted to actually, have some practical things that people can actually then use, when you start thinking about how can I learn from day-to-day events? So there are proactive safety observations. You can have quality walkarounds, observational audits that we actually say, safety huddles before a shift. You're actually a multidisciplinary team coming together to actually say, okay, any potential risks that we can actually identify, how can we mitigate that? Having debriefs, both the hot debriefs immediately after an event happens, what went well, what can we do better, how can we actually plan better for the future? Having simulations, and especially in those simulations involving multidisciplinary teams, is also really useful. And with all of these, so if you go on pressing, Nikki, you need to understand that if you're identifying any kind of a concern during any of these observations, any of these processes, it is really important to act upon them, not just recording for recording's sake. So you need to be able to escalate, you need to be able to address those concerns that are raised during these processes. And always, I think what we have been trying to emphasize is language matters, the attitude matters. So asking questions as open-ended questions, really with curiosity, that you really want to actually understand why that has happened, with an appreciative inquiry, is really important. And with all of these, it is important to have feedback loops in place. So these are some of the tools, and I really hope that you would be able to operationalize safety too. And another important aspect is involving patients and families as well. So, this was one of our key recommendations in the last report. And it is not just in aspects of individual safety for the patients, but also in organizational safety. So towards this last year, we had the introduction of a patient webpage on the SHOT website, where we have also actually then collated resources. And this is actually an evolving one. So we've also then, thanks to colleagues in the transfusion community, especially the patient representatives who are there on the SHOT steering group, as well as the NBTC subgroup as well. Like, for example, this is a document that actually tells what are the tips, for the patients who, for receiving the blood transfusions. We have also actually then indicated to the different transfusion steps, how can patients get involved as well. And similarly, for our colleagues who are actually joining from the blood services, how you can also be actually thinking about how we can actively involve the blood donors as well. Now, what else is happening in the wider NHS? So we have been talking a lot about the transfusion, and there were a few questions that came in the chat box as well about the PSERV. So I would just be mentioning that. First, there's the National Patient Safety Syllabus. This is actually released by the Academy of Medical Royal Colleges. This is the first NHS-wide patient safety syllabus that was introduced in Jan 2020. It is multi-professional, irrespective of what staff group that we are in, whatever part of the patient pathway that we are actually then influencing, it is going to actually give us the basic principles of the safety training. So the human factors, the emphasis on the systems thinking, the systems approach is actually what is emphasized there. And Health Education England is also actually then providing some free e-learning modules. If you go on to the next slide, this is available. And if you press again, this is on the e-learning for health, and there is this QR code that would be taking you. There are modules that would be actually then available for awareness and promoting this widely within your staff as well. Similarly, in the devolved countries, there are different other courses available as well. So PSERV, the NHS England, so this is specifically for England, it introduced the Patient Safety Investigation Incident Response Framework. So this was introduced in August 2022. There were some early adopters, and learning from that was actually then helped adapt to the system further. And this framework is actually setting out the approach in England to developing and maintaining effective systems. So it is more a systems approach that is actually being promoted again. And to clarify, what is the impact on hemovigilance? We worked with NHS England. So MHRA and SHOT worked with again NHS England and have clarified what is actually the impact on the various stages. So you can see this document that is there on the website if you go onto the reporting page, and that actually summarizes the impact on hemovigilance. So what next really? And I think what we have been saying is we need to embed the learning. So it is not just using the right principles and the human factors principles, using the learning from all the events, but we need to embed that interventions. We need to have a good, reliable safety culture. And we also need to actually promote the implementation of IT vein to vein. We also need to actually then partner more with patients as well as the donors. And we also need to actually collect the data on the interventions, the effectiveness of the interventions. Did we make the right decisions? And are these in the longer term sustainable and making long-term changes to our system as well? And I hope, we have managed to actually then cover and satisfy all the learning objectives. So, importance of effective incident investigation, how do we optimize the learning and share the learning widely? And even this webinar is actually one such way to actually then promote the learning as well that we have from the submitted SABR and the SHOT reports, also exploring all the factors and with illustrative cases. So we have signposted a lot of resources. All the resources from SHOT are actually then available on the SHOT website. It can also be actually accessed on via the app. So I hope you have actually then downloaded. If not, you can actually go to the app store and then just search for SHOT UK. And there is also, we are excited about the upcoming symposium. So I really hope that most of you, if not all, would be actually joining us at the symposium. There is still time to register, but very limited spaces available now. This is going to be on the 4th of July at the Etihad Stadium in Manchester. And again, I would like to actually emphasize, a big thanks to everybody involved, especially our reporters for submitting these reports, to all my colleagues in the SHOT steering group, working expert group in MHRA, who are helping us, optimize this learning from the submitted hemovigilance report, and of course to all the UK forum. So thank you all. And I think we can now go on to the Q&A.
Thank you so much, everybody. It's an awful lot of information, and hopefully there's going to be lots of questions from everybody taking part. So I don't know if anybody's seen a question that they'd like to start with first.
There's this one. The presentations have described how investigators of incidents should be appropriately trained. What formal investigation training is available for NHS staff involved in reporting SHOT reportable events? I think Shruti wanted to answer that, please, Shruti.
Yeah, thanks, Emma. And I think, that highlights one of the key points we have been emphasizing is, from all our observations in the submitted reports, those who are leading the investigations don't have much, training available. So as part of even the piece of introduction, there are lots of actually the new resources that are actually come through. Scope for training from the HSIB, which is the Healthcare Safety Investigation Branch, has actually done a lot of courses that they provide. SHOT have been actually providing more about application of human factors in transfusion. So we have been running the human factors courses virtually. And your trust may also be having several human factors courses as well that are available. And I think, Chris, you were offering some for the SABR, isn't it? So I don't know if you want to come in and then mention about that.
Yes, MHRA will also offer some targeted training for incident investigations, especially in relation to serious adverse event reporting. So simply contact us by email or phone up and we'll arrange a session.
Okay.
Fantastic. Thank you. Shall I try and find another one? There's one for, looks like Chris would like to answer this one. So it's quite a long one. So I think it's quite interesting that we are expected to look at the system to see where they can be improved. And yet many of the processes in transfusion and sample labelling are very specific and expect staff to do things in a very particular way. How can we improve the process, which seems beyond our control? So Chris, did you particularly want to answer that one?
Yeah, I just thought it's important to point out that when we talk about processes and systems, we're not simply talking about one individual task. So the task of, I think the example may have been given as accepting a sample. That is a specific task that will have a procedure, but the system surrounding that is also important. I think the questionnaire also identifies that the problems are to do with staffing and workload. That is part of the system, that's part of the process. And the reporter or the questionnaire has already identified staffing and workload as being the issues that have caused the member of staff to miss the error, then that's exactly what it is that they need to address.
Thank you. Alison, can I direct this one to you, please? Is the term human error acceptable when we are trying to adopt a systems approach to investigations?
Yeah, absolutely not. I would like to get rid of the term human error entirely, and I think we actually even recommended that. But I think it's interesting. It comes in a little bit with the one that Chris has just answered, which is it's very hard for people to get beyond the immediate thing of somebody did something wrong. They didn't do it according to the policy, or they didn't do it the way they should have done it. And if they just did it how we told them to do it, those humans wouldn't make that error. And of course, that's not the answer. Chris answered that really well about how there are much bigger system issues at play here about staffing and resources and other things. And I think there's quite a lot of work being done on actually saying the whole term human error should just be outlawed. And then it gets a bit worrying because MHRA have a whole category called human error. And I think Chris has already answered another question on the Q&A here about how things move a bit slowly in the BSQR. So I'm sure there are things Chris would like to change, and getting rid of human error might be one of them. But certainly in SHOT, would be lovely to get rid of it.
Yeah, if I could just add to that, thank you, Alison. Yeah, the term human error, I think rather than being looked at, because at the moment we can't get rid of the term, it's embedded in the blood safety and quality regulations. But rather than being seen as a root cause, it should be seen as an outcome, and it's an outcome of the failures of the system. So it literally taken is an error made by a human. That doesn't mean that it's only down to the human. As we've already said today a number of times, we're looking at improving systems, helping staff make correct choices, do the right thing rather than failing.
Thank you both. We've got another question here for Kerry. How can we address issues of procuring adequate funding for resources, including staff?
Thank you. So I would say the first thing to do is to identify your problem, and that could be using your capacity plans or your workload figures. Highlight what the risk is and what the potential mitigations are for that risk. And that needs to be escalated appropriately within your organisation, really clearly articulating what the risk is and what the potential resolution is. At that point, from the laboratory perspective, you've done your job, you've found the problem via good investigation and you've highlighted it. Of course, it might be that that resource is not available. There may be no funding for more staff or whatever it is that you happen to need to buy. And at that point, you really need to look at what other resource you've got to make it safe. And that could be stop doing something, referring something to another service, or looking at other options like IT and automation to reduce your manual workload.
Thank you. Questions have jumped around. Sorry, bear with me. Okay, so hopefully we can answer these two in the same answer. Firstly, my trust has decided not to investigate near misses. How do we address that? And something else on near misses, does PSERF impact on investigation of transfusion incidents, including near misses?
Thanks. I can kick off and then probably Chris can also be actually then answering that, because I think so near misses are also part of the serious adverse events, but only thing is that you have been picked up by some of the controls in place, whether it is actually IT controls, whether it is humans. We've also had incidents where it is patients who have actually then picked up, oh, this is not the blood that needs to be radiated, does not have the special sticker on it. So near misses, as Alison had also mentioned as part of a presentation, for us is actually valuable opportunities. And while it may not be necessary to investigate each and every near miss, it is actually taking a theme. So for example, if you're actually then seeing loads of VBITs that are actually happening, then what are actually the common themes, having the systems views, and where you're having that advantage that, okay, it's good that you have a control that has actually picked it up. Can that control pick it up every time? Can you actually then make the system stronger in any way? So I think, to me, there is absolute reason to actually then investigate and learn from the near misses. We also have a short bite on learning from near misses that you can actually then explore. And coming to the PSERF as well as the impact, now that is really, we may not have time to go to all the details. It is explained well in that document as well. And I think, Chris, if you wish to actually come in at this point as well.
Yeah, it's just to point out that PSERF as a framework, we both MHRA and SHOT back the systems improvement aspect of it. But you need to remember that blood safety and quality regulations and the good practice guide are the legal frameworks within which we have to work. So when we ask about identifying preventable causes, or root causes, we're simply asking you to look at why these errors have occurred and what measures that you can do to put in place to improve your processes that prevent them happening. So we're in line with the improvements to systems and systems approach. So don't get worried about terms like root cause analysis or root cause, because it's just simply a way of saying, find out why something went wrong.
And this question from Chris kind of follows on. These days, should we really be seeking a single root cause, as in many cases there are multiple causes? So that really follows on really from what you've said, isn't it? That you're right, there's very infrequently is there a single cause.
Yeah, the blood safety and quality regulations actually says preventable causes, and the good practice guide talks about causes as well. So it's well recognised within the legal framework that it's not single root cause, that there are multiple factors involved.
Thank you. Just select one here. How would you advise TPs, transfusion practitioners, deal with any conflicts in investigating that result as the PSERF is implemented in trusts?
I don't know what exact conflict that Brendan was actually referring to, but
I wonder if it's kind of lack of engagement. That's all I can kind of assume.
I mean, the only thing is, you know, while PSERF is actually the framework that has been introduced, so from the transfusion, as Chris mentioned, transfusion, like there are several aspects of clinical care, are heavily regulated. So, you know, we need to ensure, and that's why that slide where Karen actually mentioned earlier, is your practices are going to be influenced by several things. Yes, NHS England has actually come up with this, with the systems approach and human factors, which we also support. But equally, I think we need to ensure that it is actually what we are practicing in day-to-day life is also compliant with what is actually the regulatory requirement. So I think it is actually more improving awareness, having that engagement with the trust to actually then understand, also use the document that we have actually then produced collaboratively, and you know, involve the relevant stakeholders to actually then ensure that, okay, while PSERF does this from a regulatory requirement, this is what is required. I don't know, Chris, if you have anything to add to that.
I don't specifically. I think we've covered it, or the aspects of it, with a number of different questions. You know, if you're trying to get, you know, engagement from the wider trust, use the blood safety and quality regulations as your tool. Point out its legal status. The requirement for following the blood safety and quality regulations lies with the chief executive of that trust. They have to engage. If they don't engage, then they're in breach of the regulations.
Unbelievably, the time has flown by and we've actually only got 2 minutes left. So thank you for all of those questions. Thank you for listening and taking part. We're going to have a quick poll. But absolutely, if you've got any questions that we haven't answered or you weren't brave enough to type in the box, you can contact the SHOT team directly. You can give us an email, or Chris, I'm sure I can speak for Chris, I'm sure you'd appreciate any queries you've got. Please do get in touch. The door is always open with the SHOT team, so we would really appreciate any feedback. And if you've got any new ideas, any suggestions, we would absolutely take those on board. I can't see the little poll popping up. Oh, there you go. Thank you. So it's just a few questions, and a big thank you for taking part and listening. With the hope of improving transfusion, we would love to see people at the SHOT Symposium. It's only a few weeks away now. We're at the Etihad Stadium this year in Manchester, so we'd love to see. We've got a really interesting programme of speakers. We're all there in person, so it'd be nice to actually meet face to face again. We are hoping to get around the UK and England this year, and as was mentioned earlier, we're hoping to start some face-to-face human factor courses as well. So thank you for your time, thank you for listening, and if you want to, like I say, get in touch with the SHOT team, and if you'd like to encourage other people to watch this presentation, it should be available on the SHOT website next week. So I don't know if anybody else has got anything else to add before we run out of time. No. So thank you, everybody, and we have got further webinars coming up. We've got 2 more in July, so those are advertised on our website, and they're also in our newsletter. So if you'd like to sign up for those as well, that would be great. Okay, thank you, everybody, and thanks for taking part.